Today's topic is on cognitive decline in elderly. So this topic is of much importance and of growing significance in case of mental health as well as geriatrics is concerned. So without much delay, let's start. Okay. So as per definition, who is considered as an elderly person? Anyone wants to put in their views? So there are multiple definitions, but as per the government of India or the national policy on older persons, it is above 60. But this differs in various parts of the world. Like in USA, it is 65. And as per WHO, it is classified as three classes: elderly from 60 to 75, old from 76 to 90, and very old more than 90 years. So age is just a number, right? So it is not simply defining that if someone is 60 years old, they are an elderly person. It is more than that. That is, one has his own role transitions, how they are sharing their responsibilities, how they are adapting to the social needs. All these are actually defining who an elderly person is. So geriatrics is a specialty that deals with the physiology of aging and the diagnosis and treatment of disease affecting the aged. Now, if you see the graph, we can see that the number of persons over 60, 65 years of age is gradually increasing all over the world. And now it is going to increase further. Because of this, what can happen is that the number of persons living with dementia or cognitive decline also come into picture, and they are more prevalent. Now, when you talk about elderly, what are the changes that happens to an elderly person, right? So it is not just physical changes, it includes psychological as well as social changes. So the physical changes include the first of all, when an elderly person enters to our clinic, or when you meet with an elderly person and you are going to assess him, the first thing that we need to consider him is the sensory part, like how much they are able to perceive, like how much they are able to hear, see, no. So the sensory system plays an important role. Apart from that, they will be suffering from multiple comorbidities that includes cardiovascular system and also other systems also. But if you see, most of the even our grandparents, our parents, most of them will be taking calcium and vitamin D supplements. So most of them will have reduced muscular mass, bones will be weak, and they will have a lot of issue in their sleep. So this is the physical changes that we usually come across. Apart from this, there are social changes also, like they will be leading a retired life. There will be always a sense of lack of purpose in their life. There may be a death of spouse or a family members or their friends that usually come across. Then lack of caregivers, poor social support. Most of them will be having loss and loneliness, and they will have a lot of boredom because there is nothing to get engaged to. And most of them will be facing some issues like abuse, neglect, and isolation. Apart from this, their psychological changes are also there, like their intellectual function gradually declines, there will be memory issues, their personality and mood also changes a little bit. So considering all this in mind, we will come to the core of the topic. So when you consider the distribution of disease across an elderly, like considering all the comorbidities, psychiatric problems alone constitute about 42% of the problem. And if you see the dementia global burden, we can see that the most common type of dementia that we come across is Alzheimer's dementia, followed by vascular dementia. So if you see the prevalence among men and women, whom do you think are more affected with dementia? You can make guesses. Is it men or women who are more affected with dementia?
Men are more affected, I think.
Any other opinion? You can put in the comment also. Yes. Okay. So as per the statistics, it is the women who are more affected. The reason behind this is because they live longer, right? The lifespan, if you see, women have a longer lifespan. So the more dementia cases are getting detected in them. Then if you see the prevalence in lower middle income countries and high income countries, which do you think having the more amount of like more number of people, that is the prevalence is higher in which area? Higher middle in high income countries or lower middle income countries? You can make guesses, it's okay.
Lower income countries.
Yes. So overall prevalence, if you see, it is higher in high income countries, but if you see the number of people living with dementia, it is more so in the lower middle income countries. This is because in high income countries, there are better facilities to detect, right? So obviously the prevalence will be higher there, but when you see the number of persons living with dementia, that is higher in lower middle income countries, especially like India. So if you see the Indian statistics, we can see that in 2025 it's almost 6.35, and within maybe 20-25 years it is going to double. So if you see the longitudinal aging study of India, that is a most like a notable study in this thing, that is LASI study. In that, if you see that the Alzheimer's disease and dementia, which I have highlighted, is more so in the 60 and above, and it is same as the global pattern is going on. It is higher in females in India, and it is more so in the rural areas. Okay. Now, coming to the core of this entire topic, that is coming to mild cognitive impairment and dementia. So before going on to that, we should have some basics cleared. So first one is cognitive domains. So when we talk about dementia, most of the time we will be thinking about memory and learning alone, or else we will say the memory is declining. But it is much more than that. There are other cognitive domains also, like language, perceptual motor, complex attention, executive functions, and social cognition. So let us try and understand each one of them. So when you talk about memory and learning, there are two types of memory: verbal memory and visual memory. So can anyone of you explain what is verbal memory and visual memory? Like you can simply say that. Let's uh, let's make it interactive. If anyone of you can unmute and tell me what is the difference between verbal and visual memory.
Visual memory means what we have seen,
Hmm.
the images which are shown, or the images that we are seeing, that is the visual memory.
Hmm.
Verbal memory means what we have heard, basically.
Yes, thank you, Swaleha ma'am. Okay, so what is the difference between verbal and visual memory is that, for I will explain it with the help of an example. For example, usually we come across our parents or grandparents, or whenever we see our patients, they misplaces a lot of items. Like they will keep their spectacles somewhere and they forget where they have kept, and they keep on looking for it. Okay, so that is an example of visual memory, right? Because you have to imagine, you have to remember where you have kept things. So this is a visual memory. Now I have talked in my phone to my brother in outside, and after that my mother is asking me what you have talked to your brother on phone. So I have to recollect what I have told to him, right? So this is something like a verbal memory. So remembering conversations or remembering phone conversations, remembering the 24-hour recall, all these are examples of verbal memory. And misplacing items, not able to remember where I have kept things, is visual memory. I hope it is clear. Now, next cognitive domain is language. So language does not only mean that what you are saying or what the communication alone doesn't mean that it is a domain. It includes both expression as well as comprehension. For example, it is very common to find that people remember exactly what was the exact word, that is word recollection difficulty, or the name of the person or name of objects, may be able to tell the function but not able to tell the name exactly. Like, for example, give me that thing to write down and not able to say it is pen. So these are language domains. Then third one is perceptual motor or visuospatial, constructional, and praxis. So this is also a very common thing that we find in elderly, that people lose their way. Okay, initially it starts with unfamiliar places, like suppose traveling to a relative's place, you have to board the bus, use the map, and find where the relative's house is. So it starts initially with unfamiliar places, initially with unfamiliar places, but gradually when the dementia progresses, it will start affecting within the home only, like the familiar situations where you are not able to navigate within the home to your kitchen, to your bedroom. Okay, so that is visuospatial difficulties. Then praxis. Praxis is ability to do a skilled task. For example, something that you are well aware of. Now you are not able to do it because of the confusion. It's maybe some building up things, maybe brushing your teeth or activities of daily living. Okay, so that it's already it's already there in your minds, but when you start doing it in dementia, you have confusion with the steps, so you are not able to complete a skilled task. That is praxis. Then comes the complex attention. So when you're talking, like when you're paying attention, you have to complete one task by sitting there and finish it off. This is something that will see your sustained attention. When you're multitasking, like you're talking over phone and trying to cook a meal, that is a multitasking. So that requires divided attention. So this is another cognitive domain, that is the complex attention. Then comes the executive functions. So it's like a manager in your brain, right? So you have to plan, you have to organize your day. For example, you're cooking, which all spices, which all things to put. So you have to work. You have that working memory in you, like which is the order of things to be put, at what time you have to switch it off, like that. Then response inhibition. So it's very common when you go to the elderly people that they have a little less of response inhibition. When something comes up in their mind, they blurt it out rather than suppressing it. So this also gets affected too much in dementia. Also, judgment, decision making, and a series of IADLs, instrumental activities of daily living. All these are part of executive functions. Then comes the social cognition. That is the ability to perceive what is happening around you, how to behave in a crowd, how to feel empathetic towards others. All these are part of social cognition. So if you see the frontotemporal dementia, most of the executive functions and social cognitions will be affected. And if it is Alzheimer's dementia, your perceptual motor part will be more affected. So with this, we will define what is instrumental activities and basic activities of daily living. So instrumental activities, can anyone tell me what are instrumental activities or IADLs? So that includes management of your finances, like going to a bank, transacting the money, or paying your bills, then cooking, traveling, taking one's own medications without supervision, okay, and doing some shopping. So all these are instrumental activities of daily living, and it actually has a lot of application of multiple cognitive domains. And basic activities of daily living include the day-to-day routine that we do, like bathing, dressing, eating, toileting, and walking and transferring, right? So we should know about these in order to move ahead, because in multiple phases of dementia, in that spectrum, like mild cognitive impairment, mild dementia, moderate dementia, severe dementia, these activities are gradually getting affected. So when you talk about dementia, it's not just moderate or severe dementia. There are preclinical stages also. So it lies actually in a spectrum. So when you talk about normal aging, right? Normal aging, it's a usual question among all our elderly people that when they start having recollecting difficulties, mainly sometimes the names of their relatives, or sometimes not able to find items they have kept somewhere, they always have a doubt whether I am having dementia or not. So some part is actually explainable by their age. So something is like age appropriate cognitive decline. So we should know how to differentiate between and something that is very normal for an age and the dementia part or the MCI part. So if the functioning is getting affected, like one's daily functioning, one's instrumental activities of daily living that we discussed prior, one's activities of daily living gets affected, then definitely this is not normal aging, right? So in preclinical stages, sometimes it will be a silent phase, because the patient themselves will be aware about one's own cognitive decline. They're very much aware that something is going on, and they're not able to remember the names, not able to remember appointments, not able to remember all the items in the list. But when you go to a doctor, when you discuss the things, when you underwent a detailed psychological examination, including scales, nothing is coming up. So this is a phase when the patient knows, but the doctor is not able to detect. That is a preclinical stage. Now, gradually, it will progress on to mild cognitive impairment. In that phase, the patient is very much aware, and the patient is very much aware about the problems, as well as the family members are aware about the problems, and they come to us. And while we are detecting, there are some, okay, we do find some problems in the assessments. So in that phase, but their instrumental activities of daily living are mostly preserved. They are able to do shopping, financial things, transactions, but with mild assistance, not independently as they used to do before, but they need some assistance. So that comes the mild cognitive impairment phase. We will talk in detail about in further slides. Then once the instrumental activities also gets affected and their activities of daily living also starts getting affected, then gradually it will progress over to dementia. So based on the functioning, we can divide it into mild, moderate, moderately severe, and severe. Okay. So we have to understand from this that it lies in a spectrum. It can start with an MCI and can progress to severe dementia later. Okay. Okay. Now, coming to the differentiating between the normal forgetfulness and memory loss. So, as I've discussed earlier, it is very normal for sometimes for the elderly people to forget certain appointments, naming certain relatives. But if we give them some time, they will be able to close their eyes, figure it out, and they will come back with the name later. So, if you put up little pressure, they will be able to remember the names. They will be able to remember the dates also. But when you lose track of it completely, and you are not able to remember even after repeating the same things again, not able to keep track of the time, the month, in that case you will progress over to memory loss or maybe impairment. Then what is the normal between executive functions? Like sometimes there are difficulties that happens with the elderly people in handling finances, even though most of their cognitive domains are preserved. But once you start making too much mistakes, we will take the example of doing in the financial transaction. Usually the patient was well aware in how to transfer money, the account number. He would used to write it very precisely without the help of others. Now, when you start writing it down or maybe trying to remember things, there is some confusion that is happening, and you need to take someone along with you to do the things correctly. That means there is an impairment. Okay. Then once if someone starts cooking, okay, so cooking involves a lot of application of your cognitive domains. Like you should have working memory, you should have planning, you should have a lot of things needs to be done in an organized manner. So when the mother starts, when she starts cooking, there is difficulty in knowing misplacing the spices or confusing what spice to put after the other, or maybe they will forget to switch off the gas itself. So these things are suggestive of there is a impairment that is going to take place. So that is about executive function. Then regarding praxis or completing a skilled task also, initially someone was to do by themselves, maybe with the help of instructions, or this is an example that is shown in the figure, like building something. So initially they used to be quite self-efficient in doing things. Now they start taking help from others in order to complete the same. So there is a difficulty in praxis. Then confusion with time and place. Like for example, in normally there is difficulty in remembering the exact day. Like for example, if sometimes when we ourselves are asked whether it is Sunday, Monday, Tuesday, sometimes we have a confusion. So with 2 days it's fine. Okay, like sometimes you remember that it is Tuesday, it is okay. But when you lose track of the complete thing, like whether it is March, whether it is which year it is going on, okay, the which season it is going on, then definitely that shows that there is an impairment. Also, visuospatial, as I've told, like initially it will start with unfamiliar places, like sometimes going to a relative's place, gradually progressing to a familiar place where within the home itself they find difficulty. Then difficulty in understanding the visual images and spatial relationships. Like for example, when you are driving, so when you know that a gutter is coming ahead, you know what to do, right? Like you will slow down, and you will apply the brake and slowly take it over the gutter. But once there is an impairment in the depth perception or difficulty in judging the distance, there will be sometimes accidents also happening, right? So and also while walking on uneven surfaces, people find it difficult, they will lose their balance. So this is because of the difficulty in perceiving the depth, or maybe difficulty in the color and contrast. So there are visual problems that are happening. So this is also suggestive of a decline in cognition. Then coming to the speaking and writing. So initially, sometimes, the elderly people find it very difficult to say the exact word for that particular thing. So they will keep on thinking, and then they will come up with something later. That is normal. But when they are not able to follow through a conversation, they will stop in between the conversation and get confused what exactly to tell next. Or, difficulty in finding the name of the things. For example, that, like as I said, give me the thing to call, and they are not able to tell the name, cell phone or mobile. So these things are naming difficulties and word finding difficulties. Okay. And also in writing, they have issues, and gradually they will not be able to sign. Okay. And in the later stages of dementia, it will be very difficult for them to have this normal speaking and writing. Then this thing is visual memory that we have discussed prior, like keeping things in unusual places. They are not able to remember where they have kept. Sometimes spectacles they keep inside the freezer. So unusual places it will be found. Inability to retrace where they have kept things. And gradually, as the dementia progress, when they are unable to find their important things, they will start having suspicion towards their family members, like delusion of theft, like people are taking my things away, and that leads to irritability and behavioral symptoms. So these are also seen in dementia. Then poor judgment, like when you are handling money, the most important thing that you need is a judgment, like how much you're paying, to whom you are giving. So when they start committing mistake in that, they're not able to judge. Okay, they are not able to keep track of their interest, and they're not able to take care of themselves, not able to bath properly, or while after 3-4 days of not even changing the dress, they are not aware. So in the severe stages of dementia, it start affecting their self-care also. Then withdrawal from social life. So sometimes elderly people do refrain from participating in very noisy, crowded environments. That is actually normal. But when it happens on a daily basis, and they start refraining from their hobbies, they doesn't want to participate in any kind of team activities, remains isolated, wants prefer to be alone. In that situations, that is not normal, and that needs to be considered. That is also a part of apathy and social withdrawal that you see in dementia. Then comes the change in mood and personality. So even though elderly people have some kind of a stubbornness attitude, or when they have all of their life they have followed a routine, and when sometimes there is a change in their routine, they get a little irritable. So little amount of irritability and stubbornness is normal in the old age. But when it becomes disproportionate to the context, like getting suspicious, there too much tearfulness, getting depressed, having a lot of mood swings, and getting easily upset for trivial reasons, and blaming others that people are not taking care of me, and having suspicious ideas towards them, then that means there is something abnormal. That is part of the behavioral and psychotic symptoms associated with dementia. So with this, now I think we are clear about the cognitive domains and what is the difference between normal and abnormal. Anything that you want to ask regarding this? Any questions regarding the cognitive domains? Then we can move ahead. In the chat box, nothing.
Excuse me, ma'am. In this stage of this pre-dementia, if it is detected within the family members, if the family members assist the person to do yoga, does it help? Does it help in the sense of like dementia further progressing into Alzheimer's? Right. So it will help in preventing the person progressing further, developing into Alzheimer's disease if they develop proper if he does proper yoga on regular basis?
So,
Subsequent session will be on role of yoga by Hemant sir. So we'll discuss at that.
Okay, okay, sir. Okay. Yeah.
okay, thank you for your question. Okay.
Madam,
It will
I
be
have one
addressed.
question. Hello.
Yes. Yeah, yes.
Yeah, I didn't get that in PFC, in which type of dementia the PFC is affected.
Sorry, which type?
Prefrontal cortex.
Prefrontal cortex is affected. So it is in frontotemporal dementia, mostly the executive functions, the apathy part, and stereotypical activities will be more in case of frontotemporal dementia. So prefrontal cortex is more affected in FTD. We will talk about it in the subsequent slides in detail.
Thank you, madam.
Okay. So pre-dementia stage. So this I've already discussed about the age-associated memory impairment. So in age-associated memory impairment, only the patient is aware, and he or she will say that I'm unable to recollect the name of relatives or unable to find some objects. But there is nothing evident on clinical interview, or when you apply the scales, there is nothing coming up. That means it is an age-appropriate thing. Then comes the mild cognitive impairment, which is the early stage of memory loss. That is something that lies in between the age-appropriate decline and florid dementia. So it is somewhere in between. In this, actually, what happens is that the instrumental activities of daily living, like I told, like finance, shopping, these things starts getting affected, but the patient himself or herself is able to compensate with some strategies. Like I said, when they are going for shopping, they go with a list, write everything down. They have a planner on their wall, and they have put that appointments very clear on the things. So with some compensatory strategies, they are able to make the activities of daily living go smoothly without much difficulty. So that comes the mild cognitive impairment, but definitely on neuropsychological testing, when you do apply the scales, it will be evident that this patient is having some difficulty in recent events, maybe remembering recent events, or maybe having some partly affected executive functions, or difficulty in planning and organization would have been started by this time. Then when you come to the dementia, this is as per the DSM-5 criteria, there should be a decline from a previous level of performance in one or more cognitive domains. So it is very much important when you start discussing a case of an elderly patient with cognitive decline, we should be very much aware about their premorbid functioning, or how much they were able to do as a retired life, maybe initial part of the retirement, what were their daily routine, what all things they were able to do by themselves without help. So this is important, because once you establish a decline in this functioning alone, then you will be able to say that this patient is having dementia. If there is no decline from previous performance, then it is not dementia. Okay, so we should be able to establish that there is definitely a decline. Then the same history should be taken from the patient themselves, as well as it will be corroborated with the knowledgeable informant, and it should be evident on neuropsychological testing that is done by the clinical assessment. Okay, so once they start interfering with their independence and their everyday activities of daily living, then we can say that it is dementia. And at the same time, you should rule out delirium and other mental disorders. So delirium means it's because there is an underlying cause and they're having disorientation to the time, place, and person, which is of acute course. There will be sleep cycle reversal, which will be another class for you, I think, delirium, which will be dealt later. So this is dementia. Now, as per the ICD-11, they have made a change, like 2 or more cognitive domains are required, not just one domain. Okay, the rest of the things are mostly the same. So apart from this cognitive declines and affecting the instrumental and activities of daily living, in dementia, there will be change in behavior, personality, and psychotic symptoms. Together, we call it as BPSD, or behavioral and psychotic symptoms associated with dementia. We will deal with it later. So this is the summary of the things that I have discussed until now. So in mild cognitive impairment, what happens is that there is decreased performance in demanding settings, but they are able to develop compensatory strategies in order to function, and instrumental activities of daily living are mostly done with some minimal assistance or patient taking some compensatory strategies. When it comes to mild dementia, definitely there is decreased ability to perform the instrumental activities of daily living, and they, besides their own health, they need assistance from their family members and caregivers in order to function smoothly. Then when you come to moderate dementia, people start getting assistance in basic activities of daily living, like toileting and eating, and they need to be prompted to do the same, but they're still able to remember the names of their close family members. When you come to moderate to severe dementia, then there is chances that they start forgetting the name of their spouse also. This is a clue that we tend to find in patients. When they start forgetting the spouse's name, that means it is mostly moderately severe, and they start needing assistance in basic activities of daily living, including toileting and eating, and that is like only they will be able to stand and cooperate, but most of the things will be done by the family members, like putting water, putting the soap, and helping them with the brushing. Mostly these things are done by the caregivers. When it comes to severe dementia, the patient turns incontinent, will not be able to indicate their needs for urination or for toileting, and they lose their verbal abilities severely and may produce some unintelligible words. Their basic psychomotor skills also gets affected, like difficulty in walking. Okay, so that is how the thing progress. This is the same thing that we have explained. So as I explained about the behavioral and psychotic symptoms in dementia, so this is first one can be an aggression. So the patient can start getting physically aggressive, verbally aggressive, and resisting or lack of cooperation to the care offered by the caregiver. Then they can have repeated pacing because of the restlessness, repetitive actions, sometimes disinhibition. They will undress themselves, okay, and can get quite anxious. Then they can also become more withdrawn. They have lack of interest and amotivation. They can become very sad, tearful, and have mood symptoms, low mood, suicidal ideations also seen. They can have euphoria, pressure, speech irritability. So sometimes we can have keep a diagnosis of depression or mania in our mind, but it is not that. It is part of the dementia. It is behavioral and psychological symptoms associated with dementia. And of course, there can be hallucinations, delusions, misidentification, and suspiciousness. So one of the most common delusions seen in Alzheimer's disease is, anyone wants to guess? I have mentioned it earlier also.
Delusion of theft.
Exactly, right. So when someone is not able to find things, they have this delusion that people are taking things away. This is very common in dementia. Now, what are the questions that can be asked in order to assess dementia? So this is something that we can do in our daily practice. We can ask these questions so that it will throw the light to the cognitive domains that are getting affected. So does she forget that she has eaten and ask for food again and again? Does she urinate in an inappropriate place? Does her clothes get dirty from urine and stools? And also, is the shirt buttoned properly? Is the petticoat or dhoti tied properly? Is she able to work as a member of a team? Does she or he express the opinion on important family matters? Is she assigned, himself or herself decides to undertake an important task? Are they able to complete it? Are they able to remember the festivals like Holi, Diwali? Are they able to deliver a message that they have been told to do? Or are they able to discuss about some politics or disasters that is going on? Does they lose the way in their village? Are they able to handle calculations and money? Are they able to, is there any change in their behavior or personality? Any depression is forthcoming? So these are the questions that can be asked in order to assess the dementia. Now coming to the risk factors for dementia. So this is a figure that I have taken from the Lancet Commission that says that there are about 40% of the worldwide dementia are caused because of certain modifiable risk factors. Okay, so this is divided into different stages of life. And for example, in the early life, if someone is having less education, their baseline is very low, like maybe primary school or like that, then that has a risk that this person can develop cognitive decline in the later stage of life. Then in the midlife, having hearing loss, sensory impairment, traumatic brain injury, hypertension, obesity, taking alcohol more than 21 units per week are all identified as risk factors in the midlife. Now, when you come to the later life, smoking, depression, social isolation, physical inactivity, air pollution, and diabetes are all, have evidence that this can cause dementia later in life. And this together constitutes about 40% of the cases of dementia. Apart from that, about 60% cases, we don't know the risk, it's idiopathic. Now, apart from that, what are the protective factors for dementia? So having a high level of education, having the ApoE2 gene, high work complexity, rich social networking, rich social engagement. When you are having, always being engaged in a mentally stimulating activities, very physically active, like someone has mentioned yoga also, right? So being physically active, light to moderate alcohol intake, this is actually not of complete evidence. Like there is no study that completely prove, even though that they have been mentioned that light to moderate intake is protective. Mediterranean diet means that something that is rich in omega-3 fatty acids. Okay, then polyunsaturated fatty acids. All these are considered to be protective factors against dementia. So when you talk about dementia, it's an umbrella term, and most of us sometimes are aware only about Alzheimer's dementia. So even though it is the most common dementia that constitutes about 40 to 70% of all dementias, other dementias are also there, like vascular dementia, which is the second most common. That is constituted about 15 to 25%. Then Lewy body dementia constitutes about 2 to 20%. Frontotemporal dementia 2 to 4%, and other dementia that is caused because of Parkinson's disease, Huntington's disease, HIV, alcohol-related dementia, Creutzfeldt-Jakob disease, corticobasal degeneration, and progressive supranuclear palsy. So this is a figure that takes all the dementias together. Now I want one of you to please read this thing out. This is a case scenario. Can one of you please initiate?
Yes, ma'am.
Yes. Thank you.
Yes.
Mr. Yes, 70-year-old retired bank officer having diabetes and hypertension for 20 years developed complaints of memory problems and difficulty to manage his responsibilities as NGO officer bearer since 1 year. He was independent in most of the activities but took more time and additional effort due to memory problems. Over the next 2 years, he decreased his activities and appeared dull. He wandered away from home when he went for walking to nearby park. He was found 10 kilometers away from home, standing confused near bus stop by police. He was brought for consultation after this incident by his family.
Okay. Thank you so much. So I want all of you to think and tell me which all are the cognitive domains you're able to find from this scenario. You can put it in the chat box also. Any cognitive domain you're able to find.
Visual memory is deficit is there.
Sorry, I didn't. Visual memory. Okay.
Visual memory deficit.
Visual memory deficit. Yes. Then anything else?
Visual spatial.
Yes. So wandering away from the home and not able to come back, which is that? Visuospatial. Okay. Visuospatial memory is getting affected, right? So we are talking about which dementia here? Any guesses? Okay. Yes, exactly. So it is Alzheimer's disease. So the person that we are seeing here is Alois Alzheimer. He was the first person who have defined the case of dementia, and that this is the first patient, August Teddy, who was the first patient of Alzheimer's. So that is how we got the name. Okay. So this is how a brain of a Alzheimer's patient or a patient with dementia appears like. We can see that the brain overall size itself has reduced significantly. The sulci and gyri has widened a lot. There is a lot of empty spaces in between. So this is a postmortem finding. Then if you see the Alzheimer's brain, there is a comparison with the normal brain on the left side. We can see that the overall size itself has reduced, the sulci and are more deepened, it is widening is there, and because the brain parenchyma has very much atrophied, the ventricles has dilated, right? And you can see the next picture as the pathological slide, where you can see the amyloid plaques and neurofibrillary tangles, which are the pathological findings that you see in Alzheimer's disease. So this is about Alzheimer's. Then other dementias are frontotemporal dementia. So in frontotemporal dementia, what happens is that a person's starts having behavioral symptoms first. Memory will be spared or maybe coming later. Initially, the person will start having an change in their personality. An introvert person suddenly start becoming so much extrovert. Okay, start taking so much impulsive decisions, and they will have inappropriate, inappropriate laughter, inappropriate way of handling things. Okay, so there is a change. A lot of personality gets affected, and their language also sometimes significantly reduces. Like they will not be able to communicate. They will have a little difficulty in finding the names, finding the words. Okay, so all these things starts with frontotemporal dementia. In vascular dementia, there will be an underlying cerebrovascular event or a CVA that is happening, followed by the development of cognitive decline, and it will be much slower and very static, like a step ladder progression, we say, for vascular dementia. Then Lewy body dementia is associated with visual hallucinations, sleep talking, or RBDs, REM sleep behavioral disorders. Then there will be increased sensitivity to anti-Parkinson's or antipsychotic drugs. Okay, then Parkinson's dementia is something that is found in Parkinson's patients. That is, initially there will be Parkinson's symptoms followed by the development of dementia. So apart from this, there will be reversible causes of dementia like thyroid deficiency, nutritional deficiency, alcohol and other drugs related deficiencies. Even depression can have something like called as a pseudo dementia, right? So sometimes the patient will not be having a lot of subjective complaints of low mood, but the patient will have a lot of cognitive deficits like reduced attention, lack of concentration. So this is something like a pseudo dementia, which is actually treatable. Okay, then medication induced, like for example, someone who is on anticholinergic drug for a long time can have cognitive decline and having metabolic derangements. Okay, so these part that I have mentioned in the later part are all reversible. So it is important to do a thorough dementia workup so that we can detect anything that is there which is reversible and try to treat accordingly so that the cognitive decline is reversible. Now this is the next scenario. So who is another person can please read it out.
Yes, ma'am. The
Yes.
sex, 45-year-old married female, educated up to the 7th standard, presented with 12-month history of insidious onset, progressive illness characterized by behavioral change and functional decline. She became withdrawn and her social interaction diminished with reduced speech, verbal stereotypy, and perseveration. She also exhibited loss of empathy with diminished response to her family members' needs and feelings, decreased social interest, and decreased personal warmth. She developed difficulty in planning activities, cooking, and managing other household tasks. Gradually, she stopped doing all household works. She developed severe apathy and would not initiate even routine activities on her own. She would not do her activities even with prompting by family members. Her appetite reduced and she developed urinary incontinence.
Okay, thank you so much. So anyone, can you identify the cognitive domains?
Language.
Okay, language is affected. Then yes, social. Okay.
Social cognition.
Social cognition, very good. So social cognition is very much affected in this patient.
Perceptive motor, executive function.
Okay, very good. So everyone has actively told the answers. I'm very happy about it. So which is the dementia that we are talking about? Social cognition is affected, apathy is there, change in a little bit of personality is also noted. So
Can you repeat?
Frontotemporal dementia.
yes, it is. So it is, we are talking about frontotemporal dementia because in frontotemporal dementia, we will be able to see that there is a lot of decrease, a change in one's personality. They become a lot of withdrawn, their interaction decreases, their empathy decreases, so they are not able to relate to others. They have severe apathy. They have difficulty in doing the planning and organization. Executive functions are affected because it's the frontal lobe functions, right? So these things, and also urinary and bladder control is also lost, so they become incontinent. So from this case scenario, we are able to differentiate this from others. So this is an image that we can see that when you see the MRI image, the anterior part or the frontal part is quite atrophied when compared to the posterior parts, right? So this is an image of frontotemporal dementia. Now, what we are seeing on the left side is vascular dementia. So in vascular dementia, we can see that there are hyperintensities that are seen in the MRI. Okay, so this is suggestive that there has been some cerebrovascular events that is going on. Just around the ventricles, if you see, there are quite many hyperintensities. So these are suggestive of vascular dementia. So in vascular dementia, usually when it starts with a CVA or a stroke, following which there is a decline in the cognition, and it will remain like that for a long time, followed by another CVA event that further declines the cognition, that follows a step ladder pattern. Okay. Now on the right side, it is another picture that is showing normal pressure hydrocephalus. There, the ventricles are hugely dilated. Okay, so that there is collection of fluid in the brain that result in three things, that is global confusion, urinary incontinence, and ataxia. Okay, that is not part of this topic. Okay. So now, what is the role of mental health professionals in dementia? So our role is mainly for the early detection and screening, also to provide the counseling and psychoeducation for patients and caregivers, managing the BPSD symptoms, and addressing the caregiver burden and supporting them through interventions and training. So how do we do this? There is a step-by-step process for diagnostic evaluation. First one, we have to interview, take the proper history, including their premorbid functioning, how much they have attained decline in each and every cognitive domains which all are affected, whether two or more is affected, like that. So first we have to confirm the diagnosis. So for that, we need to do a detailed clinical evaluation, followed by the cognitive testing. There are screening tools. I will introduce two screening tools in this class. And physical examination that includes detailed neurological examination, also sending all the necessary investigation, okay, like thyroid function test, ammonia, lactate, okay, something that is different from the routine. Also, we need to send in order to figure out any reversible causes are there or not. Okay, then imaging studies like MRI, CT scan, or in special conditions like PET MRI, like that we have to order. So now I am going to introduce few of the screening tests that can be applied in our primary care setup that can be used within like less than 5 minutes. Sorry, that is accepted by respective clinicians. So I will be introducing GP-COG, or General Practitioner Assessment of Cognition. Mini-COG and MIS and 3MS are available online. You can see in the Google itself, it is available freely. So this is the GP-COG. Here we are applying two tests, like one is for the patient and the second one is for the informant. So in patient assessment, you give a simple name and address test for the patient to recall. They can learn the address from you and try to recall the address. Okay. Second one, like usual orientation test, what is the date, time, like that we can ask. Third one is a clock drawing test. Okay. So when you ask the patient to draw a clock and put the timings as 10 past 11. Okay. So many things can be detected from that. I will show you an example. So this is how a no dementia person will draw a clock, and 10 past 11, they have mentioned it very perfectly. Like the numbers are right, the small needle and the larger needle are also right. But when you come to Alzheimer's disease, you can see that there is a lot of visuospatial problems. So you can see that it is the 1 is somewhere, 2 is somewhere else, 3 is way down, right? And they are not able to, they have missed a number, 12 also, okay? And when you come to frontotemporal dementia, there is no working memory, so you don't know which follows the other one. So randomly they will assign, okay? So a simple clock drawing test tells a lot about the cognitive domains. So that is also used in this GP-COG. Then also after maybe 5 minutes, you are asked to recall the address that you have given to them. That is a recall test. Then in informant interview, you ask about the instrumental activities and activities of daily living. Because of the time constraints, you can check this. It is available in the online GP-COG. Okay. Now the another one is HMSC. That is Hindi Mental State Examination, which is an adaptation of the MMSE for Indians. So here also we are asking about orientation, attention, orientation and attention, and also mainly regarding naming, okay, repetition, then constructional apraxia. All these are assessed using HMSC, but sometimes we are not able to detect executive functions from this screening tool. That is a disadvantage. Okay, so you can take a screenshot. Then, so it is also important for us to know that when we have to refer the patients, so usually a dementia progresses very slowly. So it's insidious onset and gradual progression, right? So when something happens very fast and everything decline within maybe like 6 months, then that is of concern. So we have to see whether it is a rapidly progressive cognitive dysfunction, because there can be underlying causes like autoimmune causes, okay, and other issues are there. So whenever you find something which is having a rapid progression, immediately refer the patient, okay. Then there is worsening that is happening in activities of daily living. That is also very fastly, if it is occurring, we have to refer. Presence of any focal neurological deficits, anything atypical like headache, vomiting, fever, okay, that is not part of the usual symptom cluster. There is a significant weight loss and loss of appetite suggestive of some underlying malignancy, okay. Then if the bowel and bladder is incontinent, that means either it is too severe, okay, severe stage of dementia that needs a detailed assessment and detailed in-depth support. Then something that is causing self-injury or injury to a caregiver. So something when it reaches BPSD symptoms, like I've already told, sometimes the psychotic symptoms like hallucinations can be severe enough that they can cause self-injury or injury to others. In that case, we have to start medications, okay, in the indication for maybe antipsychotics, okay, or if it is depression, then antidepressants will also be started in case of dementia if they cause this much severe self-injury or injury to others. Then recent history of head trauma is there or associated seizures. So in these situations, we need to refer to a higher center. So assessment and investigation we have mentioned. First, we are confirming the diagnosis from detailed history and evaluation. We are also seeing the comorbidities, that is the physical as well as psychiatric comorbidities, whether these are adequately treated. Then identifying the treatable causes like thyroid deficiencies or vitamin B12 deficiencies. Explore any psychosocial issues like lack of caregivers, okay, isolation. Many a times the elderly people are living alone and the children are outside. So these things we need to address, and adequate support should be offered. Assess the caregiver burden, okay. Now, this is how we manage dementia. So basically, more of non-pharmacological management are the mainstay of treatment than pharmacological management. So this is part for all MCIs as well as dementia, early stages of dementia. We can ask, or maybe to prevent dementia itself, we have to make the patient engage in cognitive training, engaging in brain stimulating activities like, so as simple as Sudoku, crosswords, puzzles, okay, something that make the brain function. Then physical activities like regular exercises to support the brain and the health, healthy diet to be followed, fruits, vegetable, omega-3 fatty acids, and the Mediterranean diet, okay. Then making them socially active. So many times because of the age, or maybe because they are not behaving properly, the caregivers does not take them to any functions, or they refrain them from getting actively engaged in society. So this should be prevented, and we should ask them to make them engage more in functions, make them have a good team activity, or take them to functions more. Then regarding the research, like it's still there are a lot of medications under trial, and we have been using few of the medications which we will be discussing in the subsequent slides, okay. So this is the overall of the non-pharmacological management, like looking after the heart, physically active, follow a healthy diet, give stimulations to the brain like crosswords, puzzles, sudokus, and enjoy social activities. So regarding the treatment, as we all know, there is no cure yet, and the focus will be on the symptoms and the associated comorbidities. So there are few medications like donepezil, which is a cholinesterase inhibitor, memantine, NMDA antagonist, which are available. So overall, there is no proven evidence that this can reverse or but there is definitely some improvement that is noted in the overall quality of life, and also to slow down the progression of dementia. So these are usually prescribed. But if there is any side effects that is happening with this medication, it is preferable to stop these medicines than continue it. Like for example, they are not tolerating because of the gastrointestinal nausea, vomiting, diarrhea, or they are having bradycardia, which is seen in Donepezil, okay, QT interval prolongation in ECG, giddiness. So when these problems comes, it is better not to give this medication and just do the non-pharmacological management. Also, there are certain brain stimulation that is available, like transcranial direct current stimulation, TDCS, and RTMS, like repetitive transcranial magnetic stimulation. Here we are targeting few of the areas of the brain. Certain cognitive domains will get improve after this TDCS, but overall reversal of the effect is very less, and the evidence is also still going on. Then non-pharmacological management, some of the examples that we can do, like this can be taught to the caregivers and to the patient also. Like one thing is environmental modification. So suppose some person gets easily irritable in a crowded atmosphere, or maybe in a room where there's a loudspeaker. Okay, so these things need to be modified. And when dealing with an elderly, always you should prevent the fall, so railings should be there in the room. Okay, then memory training can be given, like crosswords, sudokus, like I have already mentioned. Sensory stimulation is also necessary, for example music therapy, aromatherapy. Okay, these things are in trial and found the patients to have some improvement with their behavioral issues. Simplifying the task, like explaining to them step by step, and also introducing the caregivers to the support groups of dementia that are available. Now, another thing that we need to be good is the psychoeducation part. So we should be able to share, reliable and good information from sources, and because most of them will start searching Google and will have a very different perspective. So we have to give them the good and reliable information. Then dealing with problematic behaviors, mostly people will be eager to start some medications, but we have to explain to them that if you start more and more medications for the patient, it will result in worsening. So you should learn to deal with the problematic behaviors, like some of the few examples I will explain later, and also to address the caregiver issues. Like so many of them will be having a lot of caregiver burden. They sometimes the patient does not recognize the caregiver, and that will be causing a lot of emotional toil on them. So we have to address their issues also. So some of the general tips that can be given to the caregivers are, one thing is that at any cost, the dignity of the patient should be respected, especially when they are needing assistance in their activities of daily living, including bathing, dressing. Okay, so we should make sure that their dignity is preserved. Then establish a daily routine for them. From morning to evening, like making a timetable. Okay, and also ensuring safety wherever they go, like even in the washroom, ensure that there is a rails, there's a ramp, there's a chair to sit while bathing, etc. And giving a bracelet or a necklace with their name, that is a name and address written on them when they have risk of wandering or visuospatial functions are affected. This will help. Then you should also lock the door in the night in case of wandering. Okay, then also using simple clothes to wear and ensuring the hygiene, also simplifying the task for them and not making it more complicated. Always speak to them in a gentle tone, very slowly. Okay, and repeat if it is necessary, like that. Then using memory aids, like using labels, daily sheet calendar. So when they ask about the progresses, mostly the caregivers will be in denial. They will not be able to accept the fact that the patient has dementia. So you have to take it in a very gentle manner and explain to them in detail. And also we have to tell them that usually those who are diagnosed with dementia have a shorter lifespan. Okay, but even though women tend to live longer than men, that is why we are finding more amount of dementia in women. Okay, and also how when you are living with an elderly person, there is a lot of difficulties that are faced, right? So overall they will have a lot of physical complaints, they will have a stubborn nature. Okay, and it will be challenging for the children because there will be a loss of privacy, there will be a feeling of obligation, they will have more work. Okay, so we have to highlight the benefits to them, that it results in better bonding and there is mutual assistance, and they will always prefer to be with their loved ones during the end stage of their life. But it is also important that we tell them that if they are not able to take care, then help of a assisted caregiving facilities or taking the help of old age homes is also an option if they are not able to give standard care to the patient. So these are the activities that the elderly can engage in, making a daily routine, also making them involved in some hobbies, okay? And always ensuring their safety, and under supervision we need to do things. And other practical tips, like for example, when someone starts committing mistakes in cooking, you should not prevent them from entering the kitchen. That is something, a very drastic step you're taking. So you can be there, you can help them with supervision, you can label things for them, okay? So while wearing clothes, make sure that it is very, very simple clothing, okay, and not very complicated, like 2 or 3 overalls needn't be there. And also railings in the bathroom is something that we need to be ensured. Also labeling the rooms for them, like toilet, bathroom, okay, and this one, bedroom, kitchen, like that, for them, for their ease. And also like a name tag with the address that can be given to them if there is risk of getting lost. And when giving food also, it should be mixed for them. Sometimes in the later stages of dementia, they will not be able to eat properly. So like that, you have to simplify the things for them, maybe mixing the things in a bowl and giving, like that. So also it is very important to know that physical exercise, music therapy, meditation, yoga, writing journals, doing some arts and crafts also helps a lot in these patients. So making them engaged in the day is the first thing to deal with both behavioral symptoms as well as stimulating their cognition. So these are the things. Any questions if you have, you can please share.